Well, hello everyone. Thank you so much for joining us today for this webinar on hormone replacement therapy. We're so excited to have Dr. Taniqua Miller with us today, presenting on this very important topic. Dr. Miller is a fellow of the American College of Obstetricians and Gynecologists and is recognized as a nationally certified menopause practitioner for the Menopause Society. So she brings a lot of expertise to this topic for us today. So I guess I am going to just introduce myself, Kim Fancher. I'll be your host on the sidelines here. If you have any questions, please feel free to enter them into the chat. But with that, I guess we'll go ahead and get started, Dr. Miller. Thank you so much for being part of the Positive Health webinar series on this topic of HRT. And we truly appreciate your time and commitment to, guiding women through the pivotal stages of life, including the transformative journey of menopause. I think, people will probably be very interested in learning more about you and your career, if you wouldn't mind taking some time to talk about how you got into this space and why you love doing this work.
Absolutely. Thank you so much, Kim, for having me here. I'm always excited to talk about menopause. I'm always excited to provide education in a format that is understandable, judgment-free, and understanding for all involved. So thank you for having me here. I am Dr. Taniqua Miller. I am a board-certified OBGYN and a certified menopause specialist through the Menopause Society, a certification that I've held since 2016 and very proud of. And so I have been able to see over the last 8 years in my certification how the conversation around menopause has changed. And so excited to be a part of this conversation, just giving a little bit the golden nuggets about menopausal hormone therapy. I trained as an undergrad at Yale University, where I had a BA in psychology with honors. And then I went on and completed my medical education at Harvard Medical School and my residency at University of Virginia in Charlottesville, Virginia. So I feel like I've traveled a lot and I've seen medicine practiced in a lot of different ways and have really created what I feel is the premier platform called Revival, where I am walking my patients and my coaching clients through how do they live again in this transformative menopausal journey, like you mentioned. So very excited to be here today. I was inspired to develop my practice of menopause after one patient encounter. I'm in my OBGYN residency training. We have lots of exposure to obstetrics. We learn it really well. We learn surgery really well. But unfortunately, there was a gap in my own understanding around how to manage patients in the menopausal transition. I trained in the generation affected by the Women's Health Initiative, which we'll talk about in this presentation today. And so my own understanding of how to effectively care for patients in this life transition was really lacking. And so with one patient encounter, realizing that as a clinician and as a healthcare system, that we really weren't serving these patients optimally, really inspired me to have a better understanding of how to care for this group, this demographic, and I haven't looked back. So very excited that I've exclusively transitioned my practice just to taking care of those in the perimenopausal, menopausal transitions and beyond. So let's just talk about a little bit about what we're going to actually dive into today, recognizing that we have a limited amount of time, and I do want to leave some time for questions for those who are here. And so I want to talk about menopause as a full body transition. When we look at menopause as a definition, it really focuses on the reproductive tract, but this is really a full body transition and why that's so important to recognize. I want to dive a little bit into the role of the Women's Health Initiative and how that has really impacted how hormone therapy options have been regarded in society at large. I would like also to talk a little bit more about menopausal hormone therapy, how I approach goal setting with my own patients when it relates to menopausal hormone therapy. We're also going to just touch very briefly on the role of testosterone. I know that is something that has become a question more and more, even as I practice exclusively in this space for the last 8 years, that this is creating more questions and patients wanting to know what are the benefits and whether or not they need to consider that as part of their hormone therapy treatments. And then we'll close out and have an opportunity for questions. So, as we're thinking about menopause, it is a clinical definition. Like when you look up menopause in the dictionary or any sort of menopausal manual, you will see that it's a clinical definition defined as 12 months of no menstrual bleeding. That is the definition of menopause. And so for many of my patients, they find it kind of funny that menopause, with all of kind of the stigma and the weight and all of the thoughts that come up around menopause, so heavy that it's actually like a day, right? It is the day that you've had no menstrual bleeding. And inherent in that definition makes it seem as if it's very restricted to the reproductive tract. We think of like all of these reproductive transitions when we think of puberty and pregnancy and menopause. It really seems like it's limited to the reproductive tract when in fact menopause is a full body transition. We have estrogen receptors throughout the body, right? So not just solely isolated to the reproductive tract where we start seeing irregular periods, we start seeing maybe some libido issues, we start seeing some vaginal dryness, but you can see that menopause is a full body transition where we're experiencing declines in declines in estrogen levels in the brain, acting in the receptors that regulate temperature, acting on those receptors responsible for memory and complex vigilant tasks that we need to accomplish. We start seeing maybe joint pains because we have estrogen receptors in our joints that help with that joint lubrication that we have. We start seeing loss of estrogen and the impact that it has on mood. We start seeing the impact that it has on bones. And so this truly is a full body transition. And when we're looking at whether or not menopausal hormone therapy is worthwhile or useful, I like to really ground my patients and my clients in this idea that this is a full body transition. And why this is so important is because unfortunately for many of us, when we do encounter the healthcare system, some people are told they need to tough it out. Or some folks are told, well, your periods are going to stop and everything's going to get better. But we know that it's so much more than just periods stopping. It really impacts everything related to how our well-being is and how we show up in the world. And so some of that conversation, when you do go to your doctor's office, really comes from our gap in learning as a result of the Women's Health Initiative. When I was in med school, I entered med school in 2004 after taking a couple of years off. And the WHI study came out in 2002. That was the first study that really put a big splash on display in terms of the safety concerns around hormone therapy. And so I think when a lot of people through the menopausal transition are coming into healthcare, they're encountering some of this lingering impact from these earlier studies. And so I think it's important for you to understand what the Women's Health Initiative was in the first place. It was this idea that we needed to focus on women's health, that we needed to really focus on how do we mitigate some of the risk factors that really have such a profound impact on this life skill of women. So looking at cardiovascular health, bone disease, gastrointestinal health, lots of different areas. And so believe it or not, the estrogen hormone therapy study was really one part of that. And it was specifically answering a question about whether or not estrogen plus progestin therapy could be used in the primary prevention of heart disease. Now, prior to this, there were these observations that women who were taking hormone therapy had lower incidences of stroke and heart attack. And the thought was, well, is there some protective effect for those who were initiated on hormone therapy? And at the time, there was a very specific formulation of hormone therapy that was being used. So for the Women's Health Initiative, the question was, well, could we really protect from heart disease using hormone therapy, but in a very systemic, what we call a randomized controlled way to account for any bias that may be in the study? This study recruited over 160,000 women, okay, 160,000. And what we found was that the study in the median age was in the early 60s. So a little different for how we actually would offer hormone therapy today, but that was just how the study was set up. And like I said, The range was anywhere from 50 to 79-year-old, and then they split them out into cohorts. And I'm spending a little time here because I think it's important to understand what the actual intention was. The intention was, could we prevent heart disease? It wasn't a study for anything else, but really to prevent it and look at some safety data. So what they found in that 2002 study that made a big splash was that estrogen actually did not confer a heart disease benefit. And in fact, there was maybe a possible increase in the risk of cardiovascular cerebrovascular disease in the form of stroke. Okay. It also found, which we knew from other studies around estrogen, that it increased the risk of what we call VTE or venous thromboembolism, including blood clots for this particular formulation, and that there may be also an increased risk of breast cancer. In fact, in the study, the relative risk was 1.22. I think that's what it was. It was 1.2 at least. And so a lot of people took that to mean that it translated to a 20% increase in breast cancer, and that was not what the study actually showed. And then we do know from estrogen studies previously that the estrogen did decrease the risk of fractures. So the take home was that to answer the question of the study, can we use estrogen to primarily prevent coronary heart disease? And the answer is simply no. But out of this became this whirlwind storm. And like I said, we are still feeling the impact for how this study was treated in the media. And so Wyeth, who was the manufacturer of the formulation that was used, which was specifically Pempro, which was the brand, or conjugated estrogens, and medroxyprogesterone, their stock fell by 24%. You had all of these news articles then coming out talking about, well, what do we do? There were so many people who were on hormone therapy, and then all of a sudden, everything stopped. Prescriptions for hormone therapy plummeted. And then you started seeing this new resurgence about maybe we should be moving towards bioidentical, compounded, kind of like custom hormones. And I bring up Suzanne Summers, a rest in peace, who was really a big proponent, celebrity, which you would call influencer, about moving towards the bioidentical space. But there really is a gap in terms of how we see hormone therapy being utilized following this study. And I think we're really still feeling the legacy of that now. Thankfully, we have places like the Menopause Society, a place that where I received my certification and each year attend the conferences to really stay up to date with what's going on, what's new and newsworthy about menopause, that really helps to advocate for patients who may really benefit from menopausal therapy. But this is kind of like the setting and the backdrop of where we are today, 20 years later. I'm happy to report that there are lots of studies that have actually looked at overall mortality risk, and we actually see some protective benefits, especially in those who are initiated on hormone therapy close to their menopause. We also know that all-cause mortality was not very different between those who received hormone therapy. In fact, no differences. And so that is really reassuring that when we look at kind of all-cause mortality, that there really was no difference there. And for our younger cohort who are initiated early enough, that we may see some benefit. And so what does the FDA say about indications for hormone therapy? And I wanted to just line this out here. It's indicated for vasomotor symptoms. So commonly what we think of as hot flashes and night sweats. What we see most commonly, other than bleeding changes, about 75% plus of patients who go through the transition will experience vasomotor symptoms. Prevention of bone loss, especially in those who are at high risk. So those who are of lean body mass, they may have bone diseases, they may have a family history of osteoporosis, or they themselves have experienced a fracture. We see it in premature hypoestrogenism. Those are situations where either you inherently, like in primary ovarian insufficiency, have a decline in estrogen function. Those who experience premature menopause before the age of 40, those experiencing surgical menopause for a host of different reasons, and those who are experiencing estrogen decline from ovarian decline because of radiation and chemotherapy. And it's also indicated for genitourinary symptoms. We call it the genitourinary syndrome of menopause, where you may experience increase in urinary tract symptoms, including frequent urinary tract infections, menopausal vaginal dryness, painful intercourse, and the like. So this is what the FDA is indicating for hormone therapy. We know that, like I said, menopause is a full body transition. And so there are some areas where we may be inclined to start menopausal hormone therapy to address some of those other symptoms. So let's talk a little bit about goal setting. And this is a conversation that I like to have with my patients as we're really exploring hormone therapy as an option. And there are five of them that I generally will review. So the first one has to do with this idea that menopausal hormone therapy is not hormone replacement therapy. Menopausal hormone therapy, its intention is to help with symptom management as you are going through the menopausal transition. Median age of menopause in the United States is about 51, and that transition to getting there is about 4 years. And it's not a matter of your period's here one day and your period's gone the next. Like we said, this is a full body transition. And so the idea is that we would give back hormones that your body produce, that the ovaries produce, to help with symptoms. And that doesn't always translate to replacing those hormones. In fact, the only time that we consider hormone replacement therapy are for those who have experienced premature menopause, so before the age of 40, either from ovarian insufficiency, either from surgical menopause, or those who have experienced ovarian function decline because of chemotherapy or radiation. And so this is important because it leads us to goal number two, the idea that laboratory testing is unnecessary for menopausal therapy involving estrogen and progesterone. And so I have a lot of patients who come to me that say, I want to check my hormones because I feel like things are off balance. And what we know, especially in the transition leading up to menopause, things will be all over the place. And in fact, those lab testing levels are going to be inaccurate. So what do I mean? For example, if I have a patient who is late perimenopausal, maybe starting to skip some menstrual bleeding, but having very debilitating night sweats, if I actually tested her labs at any given point, it may in fact be normal. But that does not mean that she's not a candidate for menopausal hormone therapy because her symptoms take priority. So I really want you to know that. So I have a lot of patients that they will get their hormones tested and everything will be normal. And they may have a clinician that says, okay, everything's normal. I don't know what's wrong. Nothing's wrong. Yet they still feel in that full body transition that things are off. And so this is really important to impart, especially as we are initiating therapy and titrating it, that trial and error is important because there's no lab testing that tells me what your goal treatment should be. We really go off of your symptoms. And believe it or not, everyone's different. Some may require a little bit more than others, but it really is focused on you and what you're experiencing in your body. The only exception to this that I would say is if we're initiating testosterone therapy, we do recommend laboratory testings to make sure that we're not superseding any goals that we have for the testosterone therapy. But for estrogen and progesterone alone, we don't necessarily need laboratory testing. I also talk about hormone therapy needs changing over time. We know that patients get a lot of their information from the internet. They get it from their friends, they get it from TikTok, they get it from Facebook groups. And we know that people will say, well, I'm on this treatment and I'm on that treatment. And what I will say is that when you're working with someone like me, a menopause specialist, we come up with a comprehensive plan for you. And that may mean that your hormone needs and what is good for you and your symptoms may be different from your friend, and they may change over time. So I may have someone that I'm initiating what we call systemic estrogen therapy, and I'm initiating it in one particular way. That may transition to another particular way, maybe going from a pill to a patch later on. Or it may go from, I don't know, I no longer want to have a patch or a pill that I'm taking for systemic therapy, but I really want to keep focused on my vaginal health and we continue vaginal estrogen. Again, it is not fixed. It is all based on symptom management and really what your goals are for your treatment. And it may look a little different than what you read about on the internet or in Facebook chat groups. And then number four, I always like to bring up that this midlife transition is really complex because you're also dealing with midlife and all of the psychosocial challenges that come up in that time. So, if you can imagine, you're starting to experience symptoms early to mid 40s, and maybe not having menopause until into your early 50s. Well, what else is going on in life? Maybe you have children that you're trying to launch from the household. Maybe you're a new empty nester and you're trying to figure out what your relationship looks like with your partner. Maybe you are now a new caregiver to aging parents who may have health challenges. Maybe you yourself have health challenges. So there's so much that's happening in this time frame. And what I generally will say is that some of my patients may, in fact, experience mood changes around this menopausal transition. But I always set the expectation that while hormone therapy, again, will help address some of those full body transition that we talked about in the earlier slides, it may not fix everything. And you may, in fact, need some other support services like therapy, like coaching, like some support to help what's going on in this midlife transition. So hormone therapy may not always be the full solution socially, like for some of the psychosocial challenges. And then in goal number 5, there also may be other limits to hormone therapy. I never want to forget that you are a whole human body. And so, for example, I may have patients that come to me and say, I've been having chest palpitations. I think this is menopause because I read about it and I want to start on hormone therapy. And I can never forget that hormone therapy, its intention is not to fix everything. You have other parts of you that also may need some attention. So that may require that we tap into our network of colleagues and experts and specialists to help us figure it out. So, for example, with the example of palpitations, yes, we can see that as part of estrogen decline, but I never want to forego that to say, no, let's just treat you with estrogen. I really want you to have an evaluation with a cardiologist. I want us to check out your heart to make sure that everything is healthy. And we do this in combination as we're exploring menopausal treatment options. So now I want to talk a little bit about estrogen through the life spectrum and understanding where estrogen, which is really the hot topic, and that's what we're seeing the decline of, where we produce it in our lifetime. So I'll start with the picture in the middle. That's estradiol. It's the predominant estrogen produced in the ovary. That's what we call bioidentical estrogens. That's generally what we're referring to. We see that in products that we have that are FDA approved in the form of pills and patches and gels, where we can actually give you back what the ovary, or rather a chemical structure similar to what the ovaries were producing. But there are other estrogens that our bodies produce at given times. So estriol, which is the predominant estrogen produced during pregnancy, and then estrone, which is the predominant estrogen produced after menopause. Estradiol is a very potent estrogen. Estriol and estrone less so. Estrone, being the estrogen that's produced in menopause, is really important because it's coming from the adrenal gland, but also coming from our fat cells. So we do see that for some of our patients who carry a little bit of extra weight, they may actually be producing this estrone, which could have an impact to later on health, including irregular bleeding or postmenopausal bleeding. And so something to be mindful of. So you are still, in fact, producing a little bit of estrogen following menopause. In terms of treatment options, there's lots of different types of estrogen, and I've just listed some here. Conjugated equine estrogen, or Premarin, is a very common one. In fact, that was what was used in that Women's Health Initiative. That was available at the time. You have esterified estrogen, ethinyl estradiol. You may not even be thinking about it, but this is really the predominant estrogen that is used in birth control pills, ethinyl estradiol. That 17 beta estradiol is what I mentioned, which is considered the bioidentical form of estrogen that the ovary produced. And let me make a word about what bioidentical means. It means that it is similar in the chemical structure of what your body produced. But I always tell folks, and it matters, definitely matters in terms of potency and the types of estrogen receptors that are activated in the body, and then the long-term inflammatory consequences of that. But all of these medications that we're talking about are made in labs, right? There's nothing that says that we're taking something literally organic and making it. They're all synthesized in labs. But this is most chemically similar to what you have produced from your ovary. And then, like we mentioned, estriol, and there isn't an estriol product that is FDA approved right now, but it is available on compounding. There's different types of ways that you can have estrogen. You can have it in oral tablets, which generally tend to be very inexpensive. You can have it as an estrogen-only tablet, oral estrogen, estradiol, like I said, is bioidentical. Or you can even have it in combination with progesterone, which is important for those of us who continue to have a uterus in menopause. And I'll talk about that on the next slide. There are also transdermal options. And you might say, well, what should I pick for myself? Well, we know that the oral and transdermal options are both effective, but the oral options may have a slightly increased risk of blood clots. And so when we look at something that is transdermal, especially for patients, for example, who may be smokers, while you may not be a candidate for a traditional birth control pill as a smoker, you actually can get away with estrogen therapy for menopause through the form of a transdermal option because of the lower risk of blood clots. Cigarette smoking increases the risk of blood clot formation, like we talked about from that study. And so a transdermal option may be worthwhile. There are also transvaginal options that are also available. And you'll see there's a cream and a ring. There are several different types of rings that can be used for systemic hormone therapy, but then also for therapy that's localized to the vagina, like when we talk about that genital urinary syndrome. We also have cream options that are also localized to the vagina, again, for use with menopausal vaginal dryness and the urinary complications such as frequent urinary tract infections. And so let's talk a little bit about the role of progesterone. It is important that if you're considering menopausal hormone therapy, that you also consider progesterone as part of your treatment if your uterus is present. For some, even if their uterus is not present, but sleep disruption is a really big factor, sometimes adding progesterone to your hormone therapy can also help. So I'm taking us back to 7th grade here, if you remember this graph that we probably had during our puberty talk. But the menstrual cycle is really marked by estrogen, progesterone, and what's missing from this is testosterone, but we'll talk about a little bit about that in the next couple of slides. And so progesterone is kind of like the great stabilizer of the uterine lining. The first half of your cycle is all estrogen dominant, and so you'll have the building up of the lining. And then after ovulation, progesterone gets released, and progesterone stabilizes that lining. If there is no pregnancy, both hormone levels drop, and what you experience is a period. So what you're finding here is that anytime we're giving estrogen to you in your body to help treat symptoms, we have to balance that with progesterone to make sure that we're not getting an overgrowth in the lining of the uterus, which can lead to problems with cancer or precancer called hyperplasia, even things that are benign like polyps that can cause a lot of what we call postmenopausal bleeding. The micronized progesterone, which I'll bring onto this sheet here, the different types. Micronized progesterone, which is available in an oral tablet, is actually a bioidentical option. And it actually has almost like an hypnotic effect or sedative effect. So for some folks who are having sleep disruption, they can use something like a micronized progesterone, and that will help with those symptoms. When you look at the types of progesterone available to you, lots of different types of progesterone. So we think of oral tablets and capsules. These are just some of the names of the common ones. Generally, a lot of folks will like the micronized progesterone because it is considered bioidentical and can help with that sleep disruption, but it's not very potent. And so if you have a lot of bleeding concerns, sometimes using a traditional birth control pill, if you're a candidate in the earlier parts of your menopausal transition, can be quite effective, especially if bleeding is a big concern for you. There's lots of data around the intrauterine device, especially the 52 milligram levonorgestrel devices known by the brand names of Mirena and Liletta, where that could be a progesterone protecting the lining of the uterus while you're using estrogen therapy, either in the form of a transdermal option or a pill or a vaginal ring. There are also transdermal formulations of progesterone. And so there are patches that combine progesterone with estrogen as part of menopausal therapy. And then you might see some options for progesterone creams. And so I will tell you, the data doesn't really support the use of creams specifically to protect the lining of the uterus when you are using estrogen. The idea is that the progesterone compound is very large. You might not get full absorption. And anytime, like I said, you're using estrogen, you want to make sure that you really have that lining protected. And there's nothing, you might see like wild yam, progesterone creams and things like that. And that hasn't been studied to offer the protection needed. Now, I do have some patients that will use it in isolation, and that is not an issue, but when using it with estrogen, it's very limited in terms of the data and may not actually be safe. And so I generally discourage using that as your primary form of progesterone and really using some of these other well-studied ones. And so this is really a hot topic, talking about the role of testosterone. And when we hear testosterone, we're thinking of like the bodybuilders. We're not really recognizing that testosterone does play an important role in our lives. In fact, I'm going to blow your mind. The ovary is the biggest producer of testosterone in our bodies during our premenopausal years. So I think that that's important. When you think about puberty, when the ovaries start to wake up, one of the first signs of kind of that hypothalamic pituitary ovarian axis waking up is, in fact, what we call adrenarche. And that's when we get a little bit of testosterone production from the ovaries and the adrenal glands, where we start to have pubic hair, we start to have underarm hair, we start to develop body odor and the like. And then as we start ovulating a little bit more regularly, we start seeing the ovaries take over that testosterone production. And with ovulation, you actually get a big spike of testosterone each month. And so, love this slide. I'm a little nerd about this, but we do, like I said, the ovaries will primarily produce will be the primary source of testosterone production when we're having normal menstrual cycles. And testosterone is involved in a lot. It's involved in sexual function. I always say that Mother Nature was very clever, gives us a big burst of testosterone around ovulation. That's what gives us that sexual drive, that desire, that interest. It also helps. There are testosterone receptors on the outside of the external genitalia. So you'll get that arousal and the ability for orgasm. And it's all to kind of keep the species going, right? But it's also involved in muscle development. It's also involved in mood, regulation, and energy. You might even notice that in the middle of a menstrual cycle, right around ovulation, that you get this big burst of energy. And you may, if you're at the gym, you might be able to go a little bit harder. These are some of the things that are happening in your body when testosterone is present. And so we know, though, that testosterone will decline in production as we get closer to menopause, because the ovaries, being that primary source of that testosterone production, as it goes down, it's now pretty much shifting all to your adrenal glands being that production. And I'll go back to that slide because you're getting it both from your adrenal glands, but then you're also getting it from your ovaries. And so there are some conditions where we have disorders of testosterone production if you've had surgical menopause. Like I said, you will have some production of testosterone from the adrenal gland, but during the reproductive years, the vast majority of our testosterone production is coming from the ovary. If you have something like adrenal insufficiency, if you have pituitary conditions that will affect how your ovaries are responding to the signaling from the pituitary gland, chronic illness will give a hypothalamic response. So your whole hypothalamus will have depression and you won't really have that. I think about my college students who are really stressed or they're very sick and they are stop having menstrual cycles around the time of finals. Like your body is responding to all of that. Corticosteroids, as it's going to disrupt that adrenal regulation, and sometimes estrogen replacement. So when we think about birth control pills work by suppressing ovulation, right? So that you don't become pregnant. But in doing so, it also will suppress those big kind of testosterone bursts that we get during ovulation. And so for some people, they may notice going on like a traditional birth control that they have like almost a damper to what we call like libido or sex drive. And then, of course, as we're relating to menopause, normal aging. normal aging, as you get estrogen declines, as you get the progesterone declines because you're no longer ovulating, as the ovaries are sunsetting their responsibilities, we do get that decline in testosterone. And interestingly, as part of normal aging, both men and women experience this, the lower testosterone levels. It's just that men are starting out with much higher levels of testosterone to begin with. And so, how do we use testosterone today for menopause therapy? And I wanted to just show you that the Menopause Society recommends testosterone use in conjunction with menopausal hormone therapy in very specific scenarios. So this is the DSM-5 definition of female sexual or interest arousal disorder, what we previously called hypersexual desire disorder. And it has to do with these things, characterized by the absence or reduction in interest in sexual activity, sexual thoughts and fantasy, inability for sexual arousal based on physical and visual cues or other external cues, and non-essential sensations during sexual activity. For some people, they say, it literally feels like nothing. It feels like nothingness. I have no feeling there. And it's important to note that before you can actually have this as a diagnosis, you have to rule out all other causes that could potentially be impacting this. For example, sometimes the initiation of high blood pressure medications, so certain antihypertensives, or even antidepressants or anti-anxiety medications that can have an impact to sexual response should be evaluated first before making this distinction. And then when we make this diagnosis, it's going on for at least 6 months and it's causing distress. So if you're someone that you might be experiencing this, but you're not really fazed by it, maybe you're not interested, maybe your partner is not interested, maybe you don't have a partner or whatever it is, or you're just not interested, then it's not a problem. But it's really if it's causing that tremendous stress. And so when I think about the sexual response, it is very complex. We know that interest and desire is starting in the brain. And when you look up this figure is called neural pathways regulating sexual desire in the brain. And I feel like this when I'm looking and navigating this. But we do know that estrogen, progesterone, and testosterone can play a role here, especially as we study these roles during the actual menstrual cycle when we do get those testosterone bursts that help with that sexual desire. And so this is what the global consensus position statement on the use of testosterone therapy for women states, basically that it is exclusively used for those who meet that criteria for sexual interest or arousal. I have some patients that say, I use it for energy, I use it for mood, and that's really not supported by this global consensus statement coming out from all of the big governing bodies like the ISSWSH and the Menopause Society. And so I try to stay as evidence-based as possible and really communicate with patients. This is really what's indicated here. So a couple of things about testosterone. It's been really studied, especially for postmenopausal women with female sexual arousal interest disorder or HSDD, but some of the pitfalls. One, there are no FDA approved formulations for women. It's all off-label use. And so you're really trying to kind of like match out something that is just may not be perfect. And so in fact, many clinicians like myself, we may use the male formulation testosterone levels at fractions of the dose to try to help and then do lab testing to see if in fact it'll make a difference. I'm hopeful because there are some studies that are coming down the pipeline to help with this so that we can actually get a formulation for women in the United States. But right now, we don't have that. We also don't know the long-term cardiovascular safety and breast cancer risk. It just hasn't been studied. It may be fine, but we just don't know. And so as much as possible, the counseling for patients that we don't know, and we really have to be in that shared decision-making that is this like an unknown risk that we're willing to take. It requires laboratory testing. And so we do have target goals. We call them the free androgen index when we're treating patients with testosterone to make sure that we're not overshooting or undershooting and making sure that the patients are getting the desired response. And so laboratory testing is in fact required while you're on treatment. And then there's just general caution around pellets, injections, and oral testosterone. Why? Because they may give you what we consider what we call supratherapeutic levels of testosterone that may be overshot. And sometimes with injections and pellets and oral testosterone, once it's in, you can't take it out. And so some symptoms of or signs of maybe an overshoot of testosterone is that you might have unwanted hair growth, unwanted hair loss, and kind of a male pattern baldness pattern. You may have enlargement of the clitoris. You may have a deepening of the voice, that's especially at very high levels. And generally, some of those unknown risks like cardiovascular safety and breast cancer risks that we just don't have the data for. So in closing, just a couple key takeaways that I hope that you took from this presentation. Menopausal hormone therapy is considered the gold standard of management of common menopausal symptoms. It is the gold standard. And so when I have a patient that comes to me and they're having that full body transition, that picture that I showed, and they're at that age, I will bring up hormone therapy as the option because it is considered the gold standard of care. We know that from those studies that the what we call the early group, the young group, those between the ages of 50 and 55 who were exposed to the hormone therapy, they actually did have some benefit long term. And it also provides some benefit in terms of symptom control. So that is generally how I counsel patients. The goals of therapy should be centered on symptom management. It may not fix all of the common aspects of aging. And so, really setting the expectation for what you want from this treatment is very important. There are a variety, I hope I illustrated that. There are a variety of options to meet your goals and needs for menopausal care in terms of whether you like patches or creams or gels or vaginal options. Really, whatever is part of your lifestyle and your preferences, there are options for you. And partnering with someone like me, a menopause health specialist, someone who's certified through the Menopause Society, can really be of benefit because then we're able to partner with you in that shared decision making to find the right option for you. And then finally, which kind of leads me into that final point, working with someone who's going to see you, working with someone who is up to date on all of the literature around menopausal therapy is really going to be important, especially as you're exploring your options, including things like testosterone therapy. So I want to thank you for your attention and for being here. And I am more than happy to answer any questions.
Thank you so much. I mean, the amount of information you just presented today and got into the great details of it was tremendous, and can't thank you enough for bringing that all to the table
My pleasure.
for us. We did have it wasn't necessarily a question, but more of a comment that, someone heard that progesterone can also help with brain fog, even if you don't have a uterus. Do you have any thoughts to share with that?
Yeah, thank you for that question. So the question, just for the recording again, was that progesterone can potentially help with brain fog, even in the absence of a uterus. And I would say it depends on how you're defining brain fog, because we know that a lot of what patients are experiencing is the estrogen decline more than anything. So when we think of especially concentration brain fog, the studies look at, you have tons of receptors in the hippocampal area of your brain. And so those receptors are generally like estrogen receptors. And as those estrogen levels start to decline, you start to see more difficulties with kind of like those complex tasks, like remembering things. You probably have to rely a little bit more on lists. And so I generally won't necessarily prescribe progesterone alone in that situation because I don't think that that's going to optimally give the patient the result. Now, I also, just so that you're aware, micronized progesterone helps with sleep. So if there are brain foggy issues and concentration issues related to maybe sleep disruption or something like that, because let's be real, if you haven't gotten a good night's sleep, nobody can concentrate, then yes, I would use specifically the micronized progesterone, which is considered a bioidentical progesterone, to help meet that goal in someone who doesn't have a uterus. So yeah, I may have some patients, especially in that early menopausal transition, you may not have hot flashes, but you just might have isolated sleep disruption. You might have isolated sleep disruption and a fogginess, right? Which most people will say. Then in that circumstance, I think trying to treat with a progesterone is worthwhile. But if it's really in that progressive where you're kind of at work and you're like, why is it taking me an hour to do this one simple task? Then I generally would recommend combining that with estrogen therapy to get the full benefit.
Okay. Wow. Thank you so much. We have a question saying if I'm early perimenopause, brain fog, low energy, painful menstrual cramps, are there any solutions?
Yeah. So it really comes down to what your goals are. If you like just looking at that, this is me not giving medical advice, but if I were to have someone that's kind of early perimenopause, they're starting to have some early symptoms, they may notice some menstrual cycle changes, they may notice fatigue, or they're more aware of kind of that, what I call that mid luteal to late luteal phase where your energy just plummets right before your period. Then believe it or not, I would probably recommend something like a traditional birth control pill. Why? Because it is going to give you both the estrogen and progesterone, but then also help you control your bleeding pattern a little bit more. Menopausal hormone therapy doesn't always do that. And so if I'm looking for maybe to skip periods, right, so that you don't have that kind of downward of that estrogen and progesterone in that second half of the cycle, so that you're not experiencing painful menstrual cramps, then I might consider something like that. That also may help with kind of like just generally feeling better and then doing the things that will also help get your energy up, like exercising and sleeping better and all of those things. The other thing is we know that the older that we get, that we may develop things within the uterus that need some attention. And so for someone like this, I would also recommend, okay, why are the cramps painful now? So we might need to do a little bit more investigating. We might want to look at the uterus with maybe an ultrasound to see, are there any fibroids in the ultrasound that could be causing this change in the quality of our symptoms around periods? And so there's a lot of kind of making sure that we are addressing the goals that you wish, but then also there are tons of options, as hopefully I've outlined. And then how does the treatment change? Yeah, so believe it or not, I have some patients at the very beginning of their journeys, if they're perimenopausal, they may notice that as they're moving through their journey, they may require more hormonal support. So they might notice that they need changes in their dosages. They may notice that they need a different approach to their therapy. I have some patients, for example, who are on a traditional birth control pill. They don't have any other medical issues. It's working well for them. They're not having any breakthrough symptoms. In fact, maybe they're skipping their periods. I can actually, as long as they don't develop any health concerns that would preclude them from using that as an option, I can treat them with that until age 55. Age is not a reason alone to stop treatment. It just happens that for many of us, as we get older, we might start developing things like high blood pressure and things like that. But if I have someone who's otherwise healthy without medical conditions and they're well maintained on a traditional birth control pill, I say let's keep using it. And then we start to transition. And 55 is given because it's kind of risk benefit scenario there. But then also 90% of women will have gone through menopause by that time. And so again, this is a conversation back and forth about what your goals are. I do have some patients that, maybe they didn't like birth control pills during their reproductive years and they want to explore menopausal hormone therapy. Again, that's a conversation about what your overall goals are. If we're using something, for example, like a patch and maybe progesterone, but trying to mimic the menstrual cycle, you may not have as much bleeding control, but maybe you might just feel better in general, and that doesn't matter. So again, it's that shared decision making that's really important. And I also see how do you treat weight gain due to water retention due to low dose estrogen treatments? So yes, weight gain. Well, first, let me say with water retention, it's not real weight gain. It's not real, like if I were to measure your body fat in that way from the medication, it's not that. Now you do get some weight gain from the reduction of estrogen, right? And you also get redistribution of where that weight gain goes. Because as we get older, we become a little bit more insulin resistant. As we're going through the symptoms of menopause, which are, poor sleep, maybe increased stress, we have big cortisol bursts that also influence how we store our the energy that we take in and how we store our weight. So there's a lot more to that conversation. But generally, in early parts, the water retention is generally limited. And so I generally say within the first 2 months, you might have some water retention. And this might sound completely counterintuitive, but hydrate more. So your body will hold onto more water the less you take in. So I have a lot of people that they're like, I don't want to drink, like I'm so swole. Actually, drink more because then your body holds on to less. And hopefully within the first couple of months that will get better. And so the other question is, this is a long journey. How do you know when a current treatment is no longer effective because your symptoms have evolved? How often should you meet with your provider? That's a great question. And so this is what I will say. You know your body better than me. You've lived in your body for 40, 50 years. If you notice a change, that is an indication to see your provider. Now, in terms of expectations, if you're initiating hormone therapy, then my recommendation is to give it 3 months. We look at the data and we actually see that we're going to get the fullest benefit at 3 months. For some of my patients, I will kind of take a look at things at 8 weeks, so 2 months into therapy, but we know that we're going to get the biggest bang for the treatment that where we are at the 3 month mark. If it doesn't seem like it's really addressing it, and you will know that best, not me. Again, we base this all on your symptoms. Then the recommendation would be to actually make some adjustments to therapy. And so it really is kind of like that back and forth, and being with someone who has that availability, being with someone who's willing to have these conversations, because there are some, they might start on therapy and everything is perfect. They don't need to see, maybe a quick check-in after, the first 3 months of therapy, and then I'll see you next year. But if you are having some of those kind of like growing pains around your treatment, and again, it's very much trial and error and your needs will change, then having somebody willing to partner with you is really important.
Thank you so much. And, I just really appreciate also, when you talked about the difference, and explaining between menopausal hormone therapy and hormone replacement therapy, because there is that difference there, and it's important to understand that.
Absolutely. I see a lot of my patients that really get caught up on the numbers. They're
Yeah.
like, I did this lab testing. And first of all, some of that lab testing is very expensive. And they're like, well, I did this lab testing and it said that I'm here. And then I say, but tell me how you feel. How do you feel? It doesn't matter, right? Unless we're like treating, like I said, those very specific circumstances or on testosterone therapy, I want to know how you feel. So even if your labs are completely normal, I want to know how you feel, because that menopausal therapy is hormone therapy is all about addressing your symptoms to get you feeling better.
Yes. Yep, and that's what we're here for at Positive Health, the change for the better. And you hit it well here today. So thank you
So glad.
very much for all your time. If you could go to the next slide, I'd like to just share some information to wrap up here about some upcoming webinars we have at Positive Health. We leverage the power of webinars and podcasts to build awareness on many important menopause related topics. So we've got some really great information coming up in May. Of course, here in April, once a month, we have a mindfulness webinar with Skylar Griselle. And so she's got her next one on April 24th next week. And then in May, we have an expert from Simple Therapy who is really going to talk about, managing that pain, the pelvic health and emotional stress that comes with navigating all the changes that we feel through menopause. And then in June, I just want to mention, while we're talking about hormone therapy and so forth, that we've got Dr. DeWinter will be joining us to really dive deep into what's going on with the bladder and the vagina, during this time, and how those symptoms can be managed. So if you go out to our positivehealth.com/webinars page, you'll see all these webinars ready to get enrolled in. So just go visit that site. And then the next slide, here is some information about an upcoming podcast. We release a new podcast episode the first Wednesday of every month. And so the next one will be May 1st. And here again, it's going to be with Dr. Kelly McLaughlin from Simple Therapy, talking about aches and pains and, how to manage some of the things that we feel through our pelvic floor health. All of our episodes can be listened through our positivehealth.com/podcast page. And we will be publishing them out also at some of your favorite spots where you listen to other podcasts. So again, thank you, Dr. Miller, for this great presentation, and thanks to everyone who's able to join us today. We really appreciate your time, and cheers to your good health.